Hello everyone, I am Dr. Muhammad Tariq. Today I will talk about axial spondyloarthropathy with emphasis on nomenclature, classification criteria, how we diagnose axial spondyloarthropathy, MRI feature of axial spondyloarthropathy, and different treatment modalities. Spondyloarthritis is a group of inflammatory rheumatic conditions that have a range of manifestation, mainly axial and peripheral joints involvement with extra-articular manifestation. Ankylosing spondylitis is the prototypic form of spondyloarthropathy, which usually occur in young adults with age less than 40, and it is more common in men. How we classify spondyloarthropathy? Spondyloarthropathy is an umbrella term, and it is further classified into two main groups, which is axial spondyloarthropathy and peripheral spondyloarthropathy. Axial spondyloarthropathy primarily affects the axial skeleton, while peripheral spondyloarthropathy clinical presentation is determined by arthritis, enthesitis, and or dactylitis. Axial spondyloarthropathy is further categorized into radiographic and non-radiographic axial spondyloarthritis. In radiographic axial spondyloarthritis, there are X-ray evidence of sacroiliitis, while in non-radiographic axial spondyloarthritis, X-rays are usually normal. Peripheral spondyloarthropathy includes psoriatic arthritis, reactive arthritis, enteropathic arthritis, and undifferentiated spondyloarthropathy. For this presentation, we will be focusing mainly on the axial component of the disease, that is axial spondyloarthropathy, both radiographic and non-radiographic. There are different clinical features of this condition. The main manifestation is inflammatory back pain associated with stiffness and alternating buttock pain. It can involve the upper spine and can lead to inflammatory neck pain and stiffness, spinal limitation of motion in any direction, positive sacral push test. Other manifestations include peripheral arthritis, enthesitis, acute anterior uveitis, and complications such as aortic regurgitation, apical fibrosis, amyloidosis, and subclinical ileoculitis. What is inflammatory back pain? There are different criteria used to define inflammatory back pain. The commonly used criteria is called ASAS inflammatory back pain criteria. It is having 5 components, and inflammatory back pain is present if at least 4 out of these 5 parameters are fulfilled. How we diagnose axial spondyloarthropathy? There is no gold standard test to confirm the diagnosis of axial spondyloarthropathy. The diagnosis of axial spondyloarthropathy should be based on a pattern of clinical, laboratory, and imaging features that taken together should be suggestive of axial spondyloarthropathy. We should also consider differential diagnosis. A number of clinical criteria have been developed over time, but these are classification criteria and are usually used for research purposes. These different criteria which have been developed include modified New York criteria, AMR criteria, ESSG criteria, and ASAS criteria. So let's start with modified New York criteria briefly. Its main component is radiographic changes of sacroiliitis, and they are graded as from grade 0 to grade 4 with total ankylosis of the sacroiliac joint. And radiographic axial spondyloarthritis is diagnosed if the plain film X-ray shows sacroiliitis meeting the modified New York criteria, which is bilateral grade 2 sacroiliitis or unilateral grade 3 sacroiliitis with one or more than one clinical features. This is sacroiliac joint. This is normal sacroiliac joint on X-ray, and this is sclerosis of the sacroiliac joint on X-ray. Modified New York criteria only target patients with radiographic axial spondyloarthritis, as X-ray finding of sacroiliitis is mandatory criteria. Therefore, patients with non-radiographic axial spondyloarthritis with symptom of inflammatory back pain, but no definite X-ray finding of sacroiliitis were missed. It can lead to diagnostic and treatment delay, as it takes several years to presentation from inflammation to clear evidence of radiographic changes on X-ray, and some patients will never develop radiographic changes at all. These were limitation of modified New York criteria. This led to development of other criteria. A more criteria was developed, which is having clinical parameters as well as it utilize an imaging component, but is only with a definite radiographic changes similar to modified New York criteria. Therefore, it's having the same limitation. European Spondyloarthropathy study group developed a criteria called ESSG criteria, which is having an entry point and clinical parameter along with radiographic sacroiliitis. Imaging component of this criteria was similar to modified New York criteria. MRI was not included for the diagnosis of spondyloarthropathy in these criteria. A criteria was developed by Assessment of Spondyloarthritis International Society, also called ASAS criteria. This was the first time that any criteria include imaging like MRI, HLA-B27 positivity, and spondyloarthritis feature. The entry point of a criteria is any patient under 45 years of age with chronic lower back pain of 3 months duration, and it is having 2 arms. One of arm with clinical features of spondyloarthropathy must be present. On one hand is the clinical arm, which includes HLA-B27 positivity plus 2 or more features of spondyloarthritis, or there should be imaging diagnosis of sacroiliitis plus 1 or more feature of spondyloarthropathy. Imaging include MRI suggestive of sacroiliitis or X-rays fulfilling modified New York criteria. The features of spondyloarthritis include inflammatory back pain, arthritis, enthesitis, uveitis, dactylitis, psoriasis, Crohn's disease, good response to NSAIDs, family history of SPA, HLA-B27 positivity, and elevated CRP. How do we investigate a patient with inflammatory back pain? As per NICE and EULAR recommendation, we should offer X-ray of the sacroiliac joint unless there is contraindication. If the plain X-ray film does not show sacroiliitis or an X-ray is contraindicated, then we should request unenhanced MRI. MRI should perform stir sequences and T1 weighted sequences of the whole spine and sacroiliac joint, and ASAS and MRI criteria is used to interpret the MRI. If the MRI meets the above criteria, the diagnosis of non-radiographic axial spondyloarthritis is made. CT scan may be performed in cases when X-ray is negative and MRI is contraindicated. CT scan will provide additional information on the structural damage, but the most important sign of bone marrow edema is not visible on this imaging modality. Blood tests include HLA-B27 antigen, CRP, and other blood tests to exclude other inflammatory arthritis. It is preferable to interpret T1 and stir sequences together. T1 will give information on structural lesion, while stir sequence will demonstrate bone marrow edema. On T1, fat will appear bright, that is the gluteal fat will be bright and inflammation will appear hypointense, while on stir sequence fat is suppressed and inflammation will appear hyperintense. This is stir sequence showing that the gluteal fat is dark. This is T1 sequence showing that the gluteal fat is bright. This is stir sequence showing unilateral sacroiliitis. Typical MRI lesion of sacroiliac joint in sacroiliitis may be acute lesion or chronic lesion. Acute lesion includes bone marrow edema, capsulitis, synovitis, enthesitis, while chronic inflammatory lesion include sclerosis, erosions, fat deposition, and bony bridges and ankylosis. This is stir sequence showing unilateral sacroiliitis. How do we diagnose sacroiliitis on MRI? It requires a positive MRI criteria as per ASAS, according to which the presence of definite subchondral bone marrow edema, highly suggestive of sacroiliitis, is mandatory. A single bone marrow edema clearly present in 2 consecutive slices in the same location, or at least 2 BMO lesions in the same slice is required. BMO should be in the subchondral and periarticular location. Spinal lesion on MRI include spondylitis, which is lesion at the corner of the vertebral body. Anterior lesions are called Romanus lesion. Spondyloarthritis, also called Anderson lesion. Facet joint arthritis, costovertebral joint arthritis, enthesitis of the spinal ligaments, and syndesmophyte and ankylosis. This is demonstration of spinal MRI lesion from active inflammatory lesion of arthritis in the joint, changes in the ligament, to chronic changes of syndesmophyte and fusion. As per ASAS MRI definition, positive MRI is defined as the presence of anterior or posterior spondylitis in 3 or more than 3 sites. There is high prevalence of sacroiliac bone marrow edema that occur in women immediately in the postpartum period. Therefore, a waiting period of 6 months is advisable before performing MRI sacroiliac joint in the postpartum woman with back pain. Differential diagnosis of sacroiliitis on MRI include osteoarthritis of the SIJ and lower lumbar spine, often in the anterior-superior part of the sacroiliac joint, and factious sacroiliitis in which the anatomic border are not respected and involvement may be unilateral or bilateral. Osteitis candensens alii, which is caused by the mechanical stress-related remodeling across the sacroiliac joint, usually bilateral, often in multiparous female. Is anteriorly located, well-circumscribed subchondral sclerosis, mostly in the iliac side, diffuse idiopathic skeletal hyperostosis, and systemic disorders such as hyperparathyroidism, Behçet disease, sarcoidosis, and Saphe syndrome. Axial spondyloarthritis causing inflammatory back pain and that can interfere with patient daily activities. The goal of treatment is to reduce disease activity, to prevent disability and structural damage. Physiotherapy and NSAIDs are the mainstay of treatment. Other modalities of treatment include local steroid injection, DMARDs in case of peripheral joint disease, and biologic therapy. It should be noted that systemic steroid and DMARD has no role in pure axial spondyloarthropathy. Disease activity is assessed using Buzz-Dye score and spinal VAS score. Active disease is defined as a Buzz-Dye and spinal VAS score of 4 or more than 4, despite standard trial of NSAID. A standard NSAID trial is defined as the use of at least 2 kinds of NSAIDs, each administered over a minimum period of 2 weeks at maximum tolerated dose. There is no specific NSAID preferred over other. Indication for biologic agent as per NICE guideline require active spinal disease on 2 separate occasions 12 weeks apart, while as per BSR guideline, active spinal disease on 2 separate occasions 4 weeks apart is enough. Biologic therapy include anti-TNF therapy and non-anti-TNF therapy. Until recently, there are 5 licensed anti-TNF drugs for the indication of radiographic axial spondyloarthritis and 4 for the non-radiographic axial spondyloarthritis. Infliximab is an exception in case of non-radiographic axial spondyloarthritis. Monoclonal antibodies are preferred in patients with inflammatory bowel disease and iritis. Other modalities include IL-17 blocker, that includes SECOLUNIMAB and axicabtagene. IL-17 blockers are indicated in patients with heart failure or demyelinating disease, as these are contraindication to anti-TNF therapy. IL-17 are generally not recommended in patients with inflammatory bowel disease or uveitis. If patient is non-responder to the above therapies or having contraindication, then JAK inhibitors such as tofacitinib may be indicated. Few other newer therapies in pipeline include bimekizumab and brodalumab. Initial response is assessed following 3 to 6 months of therapy, and responders should then be reassessed every 6 months. Response is defined as a reduction in the Buttock and Spinal VAS score of 50% or 2 units from the baseline. Therefore, it is very important to document baseline Buttock score and Spinal VAS score. In summary, early diagnosis of axial spondyloarthropathy can be challenging. Imaging arm and ASAS classification criteria includes plain radiography and MRI. MRI sequence minimum requirement for evaluation of axial spondyloarthropathy is T1 and STIR sequences. MRI finding in sacroiliic joint should be compatible with sacroiliitis and should be evaluated in appropriate clinical context. Remember that sacroiliitis on MRI on its own is not diagnostic of spondyloarthropathy. Thank you very much for listening.